topic we're discussing now is chronic kidney disease. First of all, if you look at the definition of chronic kidney disease is defined in patients who have got either a decreased kidney function or there is kidney damage. What do you mean by kidney function decrease? If a patient has a GFR that is less than 60 for more than 3 months, then this is what is known as decreased kidney function. What is kidney damage is, for more than 3 months, the patient should have markers of kidney damage, which includes proteinuria, and especially in this albuminuria, and we talk about albumin to creatinine ratio, and it should be more than 30 milligram per gram of creat. Okay, 30 milligram per gram of creat. This is known as albumin creatinine ratio. This is spot albumin creatinine ratio. Okay, spot albumin creatinine ratio more than 30 milligram per gram of creat. 30 milligram albumin per gram of creatinine. This is when we say patient has got kidney damage. See, the thing is easy. When we want to classify chronic kidney disease, we look at the GFR. What is GFR? Is the function of the kidney. The more the GFR, the better the function of the kidney. The lesser the GFR, the kidney function is decreased. That is the functional aspect. It's a normal function of the kidney to get a good amount of GFR. And if the kidney function is decreased, the GFR is low. GFR is functional status of the kidney. But kidney damage means there is some defect causing proteinuria. The defect damage is causing the leak of protein, and that is called kidney damage marker. The main kidney damage marker for us is albuminuria. The main kidney function marker is GFR, and later I'll show you the classification of CKD is built on these two things: kidney function, kidney damage markers, that is GFR and albuminuria together decides the stage of kidney disease for us. The important point in both these that you need to understand is only one, and that is it should be more than 3 months. So kidney disease lasting for more than 3 months is basically chronic kidney disease. Anything happening over a few days or few weeks or thing, it's not called CKD. C is chronic. To say chronic, the kidney problem should last for more than 3 months. Finally, chronic kidney disease is because of multiple factors. It's not one disease. It is a manifestation of multiple diseases. The risk factors for CKD are many. And if you look at the risk factors, you have diabetes, you have hypertension, you have cardiac causes, autoimmune diseases, HIV infection, urine infection, or many things can cause CKD. Okay, all these are various risk factors. So when we discuss acute kidney injury, some of these we already have seen. So this is the continuum here. This is a patient who's got all these variety of risk factors. Okay, so what are those? Diabetes, hypertension, family history of kidney disease. So there's a new thing coming up now that there are about 10% of chronic kidney disease who have got clear genetic polymorphisms which have been identified. It means there is some genetic role in the occurrence of CKD. So family history of kidney disease is something new that is coming up now. Okay, recurrent urinary tract infections, HIV, autoimmune diseases, all these are basically risk factors, and anybody who's got acute kidney disease in the past, I told you that could be one of the ways how they can develop fibrosis in the interstitium and progress towards chronic kidney disease. So when we evaluate these patients, whenever a patient comes with these things, we are going to screen for CKD. All diabetic patients, we are going to screen and get the urine albumin checked. So one of the important things in all patients with diabetes we are going to do is definitely look for complications of diabetes. One of the important complications of diabetes is diabetic nephropathy, and the main marker of diabetic nephropathy we check is urine albuminuria. Same thing in hypertensive patients also, kidney disease screening has to be done. Interesting thing about hypertension is it's a very non-invasive or simple test to find out patient has got kidney disease or not, because the more the nephrons are reduced, because CKD is nothing but nephron loss. The more reduction in nephron, the more the BP is going to be. So simply kidney disease itself can cause this parenchymal disease in kidney itself can cause hypertension. Okay, this is basically simply parenchymal injury itself can cause hypertension. The other way also is true that hypertension can cause nephron loss, and kidney disease. So it's the chicken and egg. What came first? We don't know. Whether hypertension caused kidney disease or kidney disease caused hypertension. The one thing we know is hypertension, CKD go together, and almost every patient with CKD is generally going to be having hypertension unless he's got some other disease causing low BP. Cardiovascular diseases also can cause CKD, and this is basically what we refer to as the cardiorenal syndromes. Autoimmune diseases, systemic infections, patients who have got renal stones, any kind of obstructive uropathy, these patients we should keep screening them for potential development of progressive kidney disease resulting in CKD. Malignancy, I told you already about family history of CKD. Low birth weight. This is an interesting thing that the nephrons that are there, they keep on forming, and if the patient has got premature birth, the number of nephrons at birth will be very less. And what's unfortunate is whatever number of nephrons are there, they don't increase after birth. So if a person has got premature birth or low birth weight, generally the number of nephrons are less, and the overall GFR status in that person cannot be normal. It will all be, the GFR reserve capacity will be less. Any past history of acute kidney injury, any reduction in renal mass, patient underwent nephrectomy in one kidney because of some tumor, then the other kidney have to follow because it can go in for progressive nephron damage. So that is one of the ways how you can see the CKD occurring. Okay, reduction in kidney mass, and if the patient is on certain drugs and toxins, they also can precipitate kidney injury. So all these are people who are at high risk, and these are the people that we should screen, and we should investigate whether they have CKD already or they are all high risk of developing chronic kidney disease. These are all what we refer to as high risk category that should be screened for CKD. So if you look at the developed world, the important causes of CKD, you can see here the most common cause for CKD is still diabetes in the world, and then you have hypertension. So these two constitute the major causes. Whether hypertension caused CKD or CKD caused, the nephron disease caused hypertension, but they are related with each other. And glomerular diseases can progress to CKD because they can cause chronic glomerulonephritis. And then you also have polycystic kidney disease, which is a reasonable percentage. They also can be associated with CKD. And there are others that are there. So all these are important causes that one should be aware of in occurrence of chronic kidney disease. So whenever you see the risk factors, what screening tools are you going to use to see if they already had started developing CKD? So most important is simply check the blood pressure. I told you BP itself can be an indirect marker of patient having decreased nephrons. Obviously serum creat, and you calculate the estimated GFR. Okay, this is known as eGFR. We have a variety of formulas that are used, MDRD formula, eGFR formula. There's so many other formulas that are there. We try to use them to decide in whether what kind of stage the patient is and how much is the GFR. The urine analysis definitely is a very, very important tool. So proteinuria, especially if it's albuminuria, then this is going to correlate with occurrence of CKD. Obviously, the important thing in the urine analysis is albumin to creat ratio. And yes, ultrasound can be done, serum electrolytes, these are all important. Especially in the ultrasound, if you hear the words increased echogenicity, loss of corticomedullary differentiation, shrunken kidneys, they're all suggestive of a chronic renal pathology going towards possibility of CKD. Another marker that is slowly coming up now, even in the management of evaluation of CKD, is cystatin C. And I told you this is a better marker of GFR and estimated GFR than creatinine, because the advantage it's got is it doesn't depend on the muscle mass, because it's produced by all nucleated cells. It's supposed to be more accurate measurement of GFR than creatinine. So we have calculators that are available for patients that we are screening with high risk to find out what their GFR is, and based on that to find out how much is the kidney decrease in function. So this is one of the calculators, and you can see this is available on this website. And this calculator is basically you're looking at the creat or the cystatin C value, the age, the gender, and in the end it is going to calculate by multiple formulas and tell you. The one that is important for us is the CKD EPI formula in normal people. People who already have CKD, who already have renal disease, MDRD formula is used. So these are the formulas that ultimately will be given, and based on that you can tell what stage and what phase the person is in. So if you look at the classification, the staging of CKD as given by KDI-GO, kidney disease improving global outcome. They are saying staging should be based on two things. One is what's the renal function, and I told you renal function we can get by GFR, and what's the renal damage, what's the kidney damage, and that you can get by albuminuria. So we look at two things to tell us what's the stage of the kidney disease. Okay, what's the function and what's the damage. As far as the GFR is concerned, for stage 1, if the GFR is more than 90 ml per minute, 2, if it is 60 to 90 ml per minute, okay, obviously it is 60 to 89 if you want to be accurate, 3, which is 40, 30 to 59, but this 3 is actually broken into 2, that is 3A and 3B, so I'll just write it at 3A and 3B. So 3A is 45 to 59 ml per minute, and 3B is 30 to 44 ml per minute. 4 is 15 to 29 ml per minute, and grade 5 is 0 to 15. So although it might appear difficult, it's not. It's pretty easy. If I write it this way, you'll understand it that it's not that difficult. So 1 is more than 90. 120 ml is normal. Anything 90 to 120 is basically stage 1. 2 is 60 to 90. 3 is 30 to 60. 4 is 15 to 30. And 5 is less than 15. So looking at this way, it does look easy. So this is the GFR numbers: more than 90, 60 to 90, 30 60, 15 30, less than 15. The only thing they have done is 3 they have split into 3A and 3B. 3A and 3B. You notice the gap is 30 30. So this 30 they have split into 2, 15 15, meaning 45 to 60 and 30 to 45 they are divided into 3A and 3B. The reason why they divided 3A to 3B is the moment it touches 3B, the complications become significant enough for the patient to be under a nephrologist care. Until that time, until 3A, the patient can be managed by general physicians also. Once it's 3B, then nephrologist definitely is involved in the management of complications. They become significant enough. So this is a rough way how we remember the various GFR values. The accurate way, you can see it here. Stage 1 is more than 90, 260 to 89, 45 to 59, 30 to 44, 15 to 29, and less than 15. The term failure should only be used for grade 5. Okay, so grade 5 generally are the ones who are going to have enough uremic complications, which are basically indications for dialysis. Once uremic complications are there, then only a patient is going to be on renal replacement therapy. So more or less, most of the people with grade 5 end up on renal replacement therapy, on dialysis, or they are going to go for transplant. This is the reason why the word failure, renal failure, has been removed for others. You call them as CKD. The word renal failure we only use for kidney failure, is only for grade 5. So one is we are looking at the GFR. The other is we are looking at albuminuria. Albuminuria is classified as A1, A2 and A3. A1, A2 and A3. A1 is if the urine albumin is less than 30 milligrams in 24-hour urine, or per gram of creat, if you compare, it's less than 30. This is spot albumin creatinine ratio, right? This is albuminuria. If it's 30 to 300 milligram albumin per gram of creat in the spot urine analysis, or if it's more than 300, albuminuria is more than 300 milligram, then that is A3. So A1, A2, A3 is less than 30, 30 to 300, which is used to be called microalbuminuria, 30 to 300, and macroalbuminuria is now A3, that is more than 300. Okay, so this is A1, A2 and A3. And if you look at the staging, you realize that staging includes both. One side you have albuminuria and one side you have the GFR. And remember, as I told you, that the GFR, it is now, I told you 3A, 3B has been made, and not only that, you can see the word kidney failure is used only when the GFR is less than 15. So one side you have the GFR and one side you have the albuminuria. Earlier, I remember when we used to discuss, when we were postgraduates, the classification was simply based on GFR. We never used to focus on albumin, the urine protein, only kidney function, and function depends on GFR. Lesser the GFR, lesser the kidney function. Kidney damage marker, we were not bothered. Now what we are realizing is that even if the GFR is low, even if the GFR is good, if the patient has proteinuria, is more worse. The more important they are trying to give is to albuminuria. The higher the albuminuria, the more worse. Even if the patient has got very low GFR, 30 to 44, But proteinuria is very minimal. This is okay. This is good prognosis, and this is what you can understand from this. See, the urine albumin is low. So what? Even if the GFR is low, nothing to worry. It's still orange. It's not that bad. But even if the GFR is good, reasonably good, if the patient has got proteinuria, then this is bad news. Meaning the importance based on this chart you can understand is more for albumin than for the GFR. So obviously both are important, but the way how the chart is arranged is albuminuria is more dangerous than a low GFR. If the patient has got low GFR without much albuminuria, it's okay. But if the patient has any albuminuria, you notice from here orange itself starts. Once it's A3, it starts only with orange, not green, not yellow. So the moment you have significant albuminuria, then this is already in a bad state and it is going to go into a red zone very soon, means it is going to be progressing very rapidly. So the idea is albuminuria is a bigger predictor of worsening in CKD and complication CKD than the GFR level actually. And the issue that we have is kidney has got a lot of functions. In a patient who's got kidney disease, most of these functions are going to get affected. So I'm not going to go into detail of these because these are all basically basic physiology and thing which you would have studied in the basic sciences. So it does play a role in filtration, in reabsorption, in secretion. It is basically playing a very important role in hormonal functions like renin, ultimately that controls aldosterone. It produces erythropoietin, which controls the hemoglobin in the blood. So for erythropoiesis, erythropoietin is important. Calcitriol, the conversion of inactive vitamin D to active vitamin D is happening in the kidney. Metabolic functions is got gluconeogenesis. It metabolizes many drugs and endogenous substances. So you see a lot of functions kidneys playing, and all these will get dysregulated in a patient who start developing CKD. So sometimes you'll notice patients who are on diabetic nephropathy, diabetes, they come and tell that they need less insulin now to control their glucose, and they have hypoglycemia, so that the endocrinologist would have reduced their insulin. So actually that's bad news because this patient must have developed diabetic nephropathy, and the kidney does play a role in neoglucogenesis. If kidney disease occurring, neoglucogenesis is not occurring, that's why the glucose is under better control with lesser insulin. Not only that, to some extent insulin is metabolized and cleared by the kidney, and if kidney disease is there, then insulin level will start becoming slightly higher. So in general, when diabetic patients tell us that they have hypoglycemia or they need lesser insulin to control their symptoms, control the glucose, it actually means bad news. This must be kidney disease has started. So the important points to remember is don't look at the urine output in patients with CKD. The urine output will be okay. The composition of urine is changed. The ability of the kidney to excrete nitrogenous waste, that is reduced. Not the volume of urine. Volume of urine is not a decider. Here the problem is composition of urine is affected. Number one. Number two, it doesn't clear out all the nitrogenous waste products nicely. They start accumulating. Number three, the catabolic activity of the kidney is gone, like breakdown of insulin, glucagon, all this kidney does, that is not happening. And fourth, obviously, many of these patients will have hormonal problems, like they'll start developing anemia, vitamin D deficiency will start resulting in bone problems, calcium problems. So all these are also things that you need to expect in a patient with CKD. So all patients with CKD, in most of the stages, you'll see that the sodium homeostasis the kidney should play is affected, and because of these patients will have edema building up, they'll start gaining weight, they'll have peripheral edema, pulmonary edema. Sometimes patient actually might have weight loss, although these are rarer features, but they might have actually malnourished state and they can go in for weight loss, not only because of the proteinuria that they are having, but also because of the other important functions that the kidney has got. So weight loss can occur, sodium wasting can occur, some patients can even have hypotension because of sodium loss. So these things are generally rare. Most of the time what you actually see is sodium retention, and that comes with more with hypertension problems. So what are the basic goal that we have in the CKD management? Okay, I'll go into individually each of them, but just to give you an overview picture first. In a patient with CKD management, what are we trying to do? We're trying to treat reversible causes wherever possible. Slow the progression of CKD is the main thing. One thing is CKD, once it starts, it's not going to recover, obviously. It is going to progress. The only thing we are trying to do is slow the progression. Okay, we have very clear treatment modalities that studies have shown that are beneficial in slowing the progression, and there are some that we are doing just for symptomatic benefit. We prevent acute renal failure because CKD patients already have low renal reserve. any insult, like a patient took a contrast, or the patient has got any insult, some drug that precipitated acute renal failure. He took an NSAID, he already had CKD, now he took an NSAID, now acute renal failure occurred. So basically, renal reserves are poor, so they should not get exposed to anything that can trigger a acute renal failure. Obviously, when complications there, the complications have to be treated. Okay, so we'll discuss the variety of complications that CKD can cause. Adjust drug dosing whenever drugs are required. Plan for renal replacement therapy. So this is a plan. This is the main thing that a nephrologist is going to do, and this is all the CKD management. So basically, what are all the interventions that we have that have been studied, that have shown proven benefit in reducing the progression? So what interventions that will decrease progression are: BP control has been clearly shown to be beneficial in slowing the progression of kidney disease. Higher the BP, more rapid kidney damage. Better control BP, the slower the kidney damage. Definitely the BP target now is less than 130/80. Getting the BP below 130/80 is an important part of CKD management. Reduce the proteinuria. Anything that decreases proteinuria is going to be beneficial. In this, the blockade of renin-angiotensin axis is definitely important. So RAS system, as you know, RAS blockade has been found to decrease proteinuria. So decreasing proteinuria is definitely a very important management options. Also, the new drugs that are coming up, the SGLT2 inhibitors, have also been found to be beneficial in slowing the progression of the kidney disease. Anything that can cause AKI, avoiding it is highly beneficial. Each insult is going to worsen the CKD by causing a tremendous amount of nephron loss. Smoking is found to be significantly increasing the CKD progression. So avoiding smoking, cessation is very, very important. Good glycemic control, especially in diabetic nephropathy. This is because it's a microvascular complication. The better the glycemic control, the microvascular complications, definitely as we discussed in diabetes, are going to be decreased. So good glycemic control and protein restriction is also important. So these are all proven benefit. They are all going to definitely reduce the progression of CKD. What else might be beneficial is using bicarb, soda bicarb, which is basically oral soda bicarb, to decrease the metabolic acidosis. This is showing promise, and although more studies are needed, but as of now, the KDIGO is approved use of soda bicarb in reducing metabolic acidosis. This has been beneficial. Using allopurinol to treat hyperuricemia, okay, to reduce hyperuricemia, even this has been shown to be beneficial in reducing the progression of CKD. So these are additional new things that are coming up now. Of all these, obviously, the most important one I have already covered is BP control, and I told you the target is an MCQ. The BP control target is less than 130/80. The preferred drugs are AC inhibitors or ARB, and generally they are given along with diuretics. So this is the recent AHA guidelines on hypertension, which I have discussed in the hypertension thing. And you can see here, in a patient with chronic kidney disease, the AHA guidelines are recommending class 1 recommendation, BP should be less than 130/80. And if albuminuria is there, then definitely ACE inhibitors are a preferred drug. If albuminuria is not there, then you can use other first line medications like calcium channel blockers. So they also can be considered. But generally, if proteinuria is there, then ACE inhibitors are important. If they cannot tolerate ACE inhibitor, then we go for angiotensin receptor blocker. So apart from this, the only thing they have not added in this that I think we need to add is use of diuretics. Definitely diuretics help us in control the pressure, because ultimately the problem is sodium and volume. So sodium volume retention is going to be one of the factor responsible for increasing the pressure, and we can achieve better control by using diuretics along with ACE inhibitors. So this is generally the management of patients with CKD as far as BP is concerned. I told you about reducing of albuminuria is definitely showing an impact, and there are multiple studies that showed the benefit of reducing the albuminuria, and generally you can understand from this, the glomerular basement membrane retains large proteins into the bloodstream. Damage to the filter allows larger molecular weight substances such as albumin to ultrafiltrate, means it will filter out. So you know that albumin is negatively charged, the basement membrane is negatively charged, it repulses the albumin, but once the damage occurs, albumin will start spilling out. Tubule damage may result in decrease in tubular absorption of proteins in the tubules. More proteins appear in the urine, and increased urine protein may be definitely a sign of kidney injury, and actually the protein itself may cause more harm. So reducing proteinuria is definitely a very important modality to prevent progression of CKD. And how do we reduce proteinuria? One of the most important way is simply giving ACE inhibitors. Okay, so reduction of proteinuria by ACE inhibitors or ARB. Oral bicarb, this is the study, and this is a 2009 study that is showing oral bicarb as beneficial in reducing the progression to end stage renal disease. You can see the big difference between the intervention and the control in the amount of dialysis free survival. So bicarb is also now approved in the management of patients with CKD. So ultimately, what we have realized is key when you look at the patients, what stage of CKD actually is a problem for us. Until what stage is okay, and from what stage onwards the complications really start showing their face. Each of the complications obviously will discuss the management, but I just want to show you the overall picture. And you can see in this that if you look at the GFR, the moment it starts going to 3B, there's a reason why they split 3A into 3B. You can see 3B here, 3A over here, right? 3A and 3B. And then after that, obviously less than 30 is grade 4 and less than 15, is going to be grade 5, right? So you notice the various complications of CKD, anemia, hypertension. These are all major functions of kidney that are gone. So you're seeing all these things. Okay, anemia is going to be there, hypertension there, vitamin D deficiency, acidosis, hyperphosphatemia, low albumin, hyperparathyroid, and all these are going to cause the patho and cause increased mortality and problems in CKD. So all these we are trying to manage. But when do they really become a problem? See, anemia and all these hypertension and most of these things, except for hypertension, which is a cause for CKD, which percentage is high, but most of the other things you can see anemia, vitamin D deficiency, acidosis, all these are less than 10%. When the GFR is stage 2, when it is stage 3A, the percentage is not high. So where the percentages start rising is 3B onwards. If from 3B onwards you can see anemia becomes 22%, this starts crossing the 10% mark, 18%, you can see 44%, that is hyperparathyroid. So the lower the GFR, the higher the stage of the CKD, the more the complication. Now you see most of them are having complications like anemia, then 50% of stage 4, hyperparathyroid is there, 72% of them. All these problems are increasing. So the idea is the more the advanced state of CKD, the more significant the complications are going to be. In the initial stages of CKD, stage 1, stage 2, the problem may not be that much. So let's start with the individual complications and start correcting that, because each of these definitely has an impact in the overall symptoms of the patient as well as in the progression of the disease process. So if you look at anemia in patients with CKD can occur because of multiple factors. It has been found that the RBC normally live for 120 days. The RBC survival is supposed to be decreased in patients with CKD. There is a problem in erythropoiesis, and one of the major reasons for decreased erythropoiesis is erythropoietin, which is produced by the kidney, is decreased. Many of these patients also have combined iron deficiency state, and the iron deficiency also adds to the problem, and this is the reason. You can also see the disease inflammation results in anemia of chronic disease. So anemia of chronic disease, which is basically because of a high hepcidin, that might be the problem. So a variety of factors are responsible for causing anemia in patients with CKD. It's not just a erythropoietin problem, it can be iron deficiency, it can be an anemia of chronic disease, and it can be simply decreased RBC survival that is known to occur in these patients. Sometimes they might be having blood loss because uremia, platelets will not work, and chronic blood loss might be there. So these are all ways how anemia can occur. So whenever we are looking at a patient with erythropoietin stimulating agents, that's one of the treatment options that we have. You should have corrected iron first, and you should have ruled out other causes first before giving erythropoietin to patient. So this is a very important concept in the management of these patients. Definitely in the treatment we are going to use erythropoietin, which is basically erythropoietin stimulating agents. But before giving erythropoietin stimulating agents, the step 1 of the process is find out if the patient has got low iron and correct iron deficiency. Without correcting iron deficiency, erythropoietin is not allowed. So if you look at this, it gives you an idea about the various things that are responsible for creating anemia. One is lack of iron, one is lack of erythropoietin, that is the main thing. But apart from that, uremic toxins and elevated parathormone, they also play a role in inhibiting the colony forming units and decreasing the iron availability. Okay, so uremia toxins are responsible. Parathormone also might be causing some problem here. Inflammatory cytokines and hepcidin. As you know, hepcidin is playing a very important role in anemia of chronic disease. And ultimately, it's simply blood loss itself because of uremic platelets. The bleeding can occur and iron deficiency can create the problem. So iron deficiency, all these things together can be responsible for causing the patient to have iron deficiency, anemia in patients with CKD. So obviously one should investigate and rule out all the potential causes of the anemia. Definitely one should not miss in the backdrop of CKD that somebody has got some malignancy, and that could be the reason for the anemia. All those should be basically eliminated. Typical anemia workup we have to do. The iron supplementation that we go for in patients is generally oral iron doesn't work that well in a patient who has got CKD because of the GI dysfunction and edema and all that. So generally it needs parenteral, and IV iron is generally what is needed in these patients. You can go for either iron sucrose, gluconate. Generally the ferrous gluconate is the preferred because it is got larger doses and it can be given very easily to replenish the iron stores in lesser in lesser settings. So iron sucrose you can't give large doses at a time, so you have to give multiple times. You want to avoid multiple sessions, then ferrous gluconate is just generally considered a better option. Important point is avoid iron infusion if patient has any infection in the background. So infection should be ruled out before giving iron. Also, do not give iron supplementation in anybody whose ferritin is already high, and if the ferritin is above 1000, particularly above 800, don't give iron. Only after correcting the underlying causes and ruling out other things, we are going to go for erythropoietin stimulating agents. The erythropoietin stimulating agents that are there are erythropoietin alpha, erythropoietin beta, darbepoetin, and continuous erythropoietin receptor activator. This continuous erythropoietin receptor activator is a recent thing, and it is also called as methoxypolyethylene glycol epitoin beta. So the full names are not really required. Just know erythropoietin stimulating agents are used. Of all these, Sera has got a continuous action, so it's got very long half-life, and that is the best. Then darbepoetin also is there in this order generally, but generally the cheap ones are erythropoietin alpha, and they are also used. So basically, these are all the various types of erythropoietins that are available that we can use. The more recent generations one obviously are superior. Darbepoetin, Sera, they are better. As far as the metabolic acidosis is concerned, I already told you we need to give the patient soda bicarb. When you're managing metabolic acidosis, then the target bicarb you are going to achieve is 23. Okay, correct the bicarb until it starts becoming 23. It starts crossing 23 milliequivalents per liter. This is a target bicarb, serum bicarb that you are going to get. To achieve this target bicarb, patient should be put on oral soda bicarb. What is the benefit of giving bicarb in the patients? What we are understanding is when the acidosis is there, as you know, kidney disease generally accompanied with metabolic acidosis. When you have acidosis, one of the things the kidney will do is it will produce ammonium to buffer the acid. This is produced in the kidney. This ammonium is supposed to activate complement. Excess ammonium activates complement, and complement cascade is supposed to be one of the reasons for tubular interstitial fibrosis. So ultimately, CKD is nothing but interstitial fibrosis and tubular atrophy. Okay, this is what we refer to as IFTA, interstitial fibrosis and tubular atrophy. So basically, we now have evidence to show that, and this is a study that has been published, and you can see this is showing high ammonium activate complement, more complement causes tubular interstitial fibrosis. To reduce the ammonium, we need to reduce the acidosis, and that's the reason why oral alkali is used in the treatment to prevent this complication. The biggest problem you will see in these patients actually is connected with phosphorus. The phosphate levels are going to be increased in patients with CKD, and this is generally accompanied with a low calcium and a high parathermone. The reason why phosphate is increased obviously is the exit route of phosphate from the kidney is blocked because of the decreased number of nephrons. Calcium is low in any renal disease. You know, calcium is going to be low partly because of the phosphate binding, partly because vitamin D is not produced in the kidney, and the parathermone increases to maintain the calcium. The big problem is the phosphate actually, because calcium phosphate levels, particularly high phosphate, when it starts crossing, this multiplication factor is very important for us. This multiplication factor, if it crosses 55, there's a very good chance of calcification occurring of the vessels, and the big danger is calcification can occur in the coronary arteries also, and that can precipitate ischemic heart disease. Okay, so coronary artery damage can start occurring when you get a calcium phosphate multiplication factor crossing 55. So one of the reasons why this number crosses is because of the very high phosphate. We don't want this phosphate to go up, and we are trying multiple ways how to reduce the phosphate. The multiple ways how we decrease the phosphate is, first is dietary phosphate restriction. Okay, chocolates, nuts, whatever have phosphate, they have to be reduced. Okay, dietary phosphorus reduction. Second is phosphate binders. Phosphate binders are classified into either calcium containing or calcium free phosphate binders. So either they contain calcium, especially when a patient has got low calcium, we can give calcium containing phosphate binders that will correct the calcium also and reduce the phosphate also. If the calcium levels are already okay, then you go for calcium free binders. Many of these patients might need vitamin D supplementation because the vitamin D synthesis of the kidney that is gone. So you need to give vitamin D correction. Obviously all these we measure only when you measure and the vitamin D levels are low, then you start correcting. Generally for correction we go for active vitamin D because the 25 hydroxy D is what we typically measure to get vitamin D. The 25 hydroxy D gets converted to 125 hydroxy D. That conversion not occurring in the kidney. So there's no point measuring 25 hydroxy D. We need to measure 125 and give 125 in the treatment. So treatment is basically calcitriol. One of the big problem is because of the lack of calcium, the body produces, the parathyroid gland produces huge amount of parathormone. This parathormone is not helpful because the very high parathormone might start breaking the bone and start pulling the calcium out, and this results in renal osteodystrophy. The combination of high parathormone, low vitamin D, all these is going to cause renal osteodystrophy, and this can result in progressive bone damage. And the problem is that when parathormone is produced because of lack of calcium, that is called secondary hyperpara. Patient has secondary hyperpara. So basically the feedback, we cover this aspect in endocrine. When calcium is low, the parathyroid gland by feedback produces parathormone. Okay, whenever the body calcium is low, by feedback the parathyroid gland produces high amount of parathormone. Because calcium is low, parathyroid gland produces parathormone. This is called secondary hyperparathyroid. It's secondary to low calcium. If you remember, we discussed in endocrine that if there is a parathyroid adenoma, by itself it's producing too much parathormone, not because of feedback. That is called primary hyperparathyroid. This is secondary because of low calcium, parathyroid is producing parathormone. So this is normal physiological feedback response called secondary hyperpara. The problem is that patient in chronic kidney disease might be having secondary hyperpara for such a long time that sometimes in the parathyroid gland these chief cells undergo adenomatous change, and these chief cells, if they convert into adenomatous state, then they start producing too much parathormone. Now they are not even listening to feedback, they go on producing excessive parathormone, and this excessive parathormone will cause more and more bone damage, and actually the calcium may start going above normal. So calcium high, phosphate high, parathormone high, all these are high. It indicates the patient has developed tertiary hyperpara. The big problem is that tertiary hyperpara is accompanied with a significant amount of bone damage, resulting in a very severe stage of renal osteodystrophy, causing Rugger-Jersey spine. And the other thing, Rugger-Jersey spine, and also it can cause osteitis fibrosa cystica. So these are all because of very severe parathormone increase, and we want to avoid this state. So to prevent, obviously tertiary hyperpara only occurs in patients with secondary hyperpara, which is generally seen in CKD patients. So to trick the parathyroid gland to stop producing too much parathormone, which can be harmful actually, we use a drug that looks like calcium, gives feedback just like calcium. This drug that behaves like calcium and gives feedback to parathyroid gland is called cinacalcet. Okay, Sensipar, cinacalcet. This cinacalcet is a calcium mimetic drug. This is known as calcium mimetic drug. And this calcium mimetic drug helps reduce the parathormone level. So this has got a very important role in the management of patients with CKD. We want to reduce parathormone. We have only two options: either trick the parathyroid that calcium is there and we use a drug that looks like calcium, that is called cinacalcet, or we have to go for parathyroid resection, and parathyroid surgery is also one of the approved treatment options for the patient in management of CKD. The problem is whenever parathormone is high, definitely there is increased risk of fractures. As I told you, calcium phosphate product is very important, and you can see the calcium phosphate multiplication factor, if it crosses 55, calcification of vessels can occur. The danger is calcification can occur in the coronary arteries as shown in the image there, and that is bad because any coronary artery problem is going to increase the risk of cardiac death. So one of the most important ideas to understand is one of the most important causes of death in patients with CKD is ischemic heart disease. Okay, partly because of the phosphate causing inflammation and calcification of the vessels, partly because of the toxins not being cleared out of the kidney. We know now inflammation itself is an important factor causing atherosclerosis. So this is a good chart summarizing the various problems that can occur in patients with CKD. Definitely we have to monitor parathormone levels starting from stage 3 onwards. Definitely vitamin D status has to be checked. From stage 3 onwards, vitamin D status has to be checked and treat as necessary, treat the acidosis, give dietary phosphate restriction, give phosphate binders. So this is starting from stage 3 onwards. So stage 3 onwards, our job starts for calcium, bone, vitamin D, all these starts becoming important. So in stage 4, we consider using vitamin D supplementation. We can also consider using these other drugs like paricalcitol, calcitol, all these are other vitamin D sterols. Stage 4, calcium mimetics, I told you cinacalcet. When you try to dialyze, we try to dialyze and give calcium in dialysis. Dialysis regimen, we try to limit calcium intake and ultimately we go for parathyroidectomy. And ultimately in stage 5, the intact parathormone level should be 15 to 300. That's a goal that we have. Calcium should be maintained normal, phosphorus should be maintained normal, otherwise the patient is going to have problems. So definitely in CKD5, parathyroidectomy, limit calcium intake, all these things we are trying. Okay, this is all for stage 5. So this is stage 5, this is all for stage 4, and then for stage 3 you can see. So this chart is a good summary of all the things that can be done in management of patients with CKD. The rough idea of it already I've covered for you. Here individually you can see the various stages and what all additional is being done in the management of these stages for calcium, phosphate, parathormone and vitamin D. So what are the phosphate binders that are there? The phosphate binders are sevelamer. Okay, all these are phosphate binders. Then we have lanthanum, sucroferric, oxyhydroxide, and finally we have ferric citrate. So these are all phosphate binders. Sevelamer is the most widely used one. Then we have lanthanum, sucroferric oxyhydrate, and ferric citrate. All these are referred to as phosphate binders. One of the important problems, so basically as you can see, we are just trying to find out all the important complications that can occur in CKD and try to manage that. Also, when the patient develops uremic symptoms, now what are the uremic symptoms? Anorexia, nausea, vomiting, pericarditis, neuropathy, okay, peripheral neuropathy. The list of uremic symptoms is big, just the important ones I'm listing down. In the CNS symptoms, the patient can have seizures, delirium, sometimes may go into coma. So these are some of the important the uremic symptoms that can occur. So obviously apart from this, pulmonary edema, dyspnea, all these can also be there. So they're all important uremic symptoms. So when patients start developing these uremic symptoms and clinical examination shows uremic fever, this is the breath that this patient have got, or they have got pericardial rub, this is a very important marker to suggest that the patient has got clear signs of uremia now. So these are basically all these things, the platelet dysfunction, okay, you can take a look at this platelet dysfunction, uremic fever, hypertension, neuropathy, altered consciousness, pericardial rub. All these are important features that might be accompanying the patient developing uremia. So if this is there, then definitely this patient is generally having a GFR less than 25. Most of them might be in grade 5, that is less than 15 ml GFR, and that's when they start developing these kind of manifestations. This is when you need to start planning this renal replacement therapy. That means the patient should be prepared mentally for dialysis options or a renal transplant. You should start creating a vascular access so that timely dialysis can be started. Okay, vascular access, possible fistulas, graft, all these should be considered. So these are the plans when the patient start developing grade 4 itself, all these things should be considered, and by grade 5 many of the patients will start developing uremic complications and they eventually will end up on dialysis. Definitely, one of the problems that can occur in these patients, the more advanced the kidney disease, the more likely they'll have hyperkalemia. So hyperkalemia management is very, very important, and we've discussed that on our electrolytes. So basically, hyperkalemia, calcium gluconate in the acute patient, and basically most of the time in a CKD kind of scenario, it is decreased potassium intake. And apart from potassium intake, potassium binders become very important, in which the two important ones that are there now is patiromer and zirconium. Both these are the new potassium binders, and they're supposed to be far better than Kxalate. Kxalate was used earlier. This is sodium polystyrene sulfonate, and sodium polystyrene sulfonate has lost favor because of intestinal necrosis, so not preferred anymore. What is used now is patiromer and zirconium. Okay, apart from that, obviously, hyperkalemia, we know what can increase it. Beta blockers can worsen it. ACE inhibitors can cause any potassium sparing diuretic can be triggering it. So you have to find out the trigger that is causing hyperkalemia and stop it. Give dietary restriction of potassium. Give these things, patiromer, zirconium, they are potassium binders. And obviously, if hyperkalemia already there, then we're going to use the treatment plans of insulin glucose, okay, diuretics, which are non-potassium sparing. So these are all important ways, and if patient is already on dialysis, obviously dialysis becomes an important option. So these are all how we manage a patient with hyperkalemia. In general, in a patient who's got a CKD, the general thing that we have is complications of CKD should be managed. So you can see here for sodium balance, we are basically preventing sodium retention and overload, and we're doing that by doing sodium restriction and diuretics. Potassium is a problem, hyperkalemia is known to occur, so we give dietary restriction, avoid NSAIDs, and potassium binders might be required, like zirconium or patiromer. They are becoming important. Acid excretion we don't want, because fibrosis can occur because of metabolic acidosis, so we use soda bicarb. Okay, soda bicarb is going to reduce the amount of acidosis, reduce ammonium, and reduce fibrosis. Calcium is the biggest headache. Calcium, and more than calcium, is phosphate actually. So we are going to make sure the phosphate is decreased. This is what you see in the lab first. Phosphate is high, parathermone high, low calcium, low calcitriol. These are consequences of CKD. So basically, we are going to reduce the phosphate by using phosphate binders. We use phosphate dietary restriction, and ultimately we trick the parathyroid to stop producing parathermone by using calcium mimetics like cinacalcet. Erythropoiesis is an issue, and to correct that anemia, I told you before giving erythropoietin, definitely iron replacement has to be done. Other cause of anemia should be ruled out, then only we go for erythropoietin stimulating agents. So this is generally the plan that is followed in patients with CKD. So we've looked at a variety of complications in CKD. We looked at what studies have shown, what will show prevention or slowing of progression of CKD. In this, I told you BP is very important. Get the BP down below 130/80. Proteinuria is important problem, and actually proteinuria and BP together we can solve by just using ACE inhibitors. As long as the patient's potassium is not very high and they are not going to grade 4 or grade 5 CKD, generally we don't have to worry about ACE inhibitors. They are going to be good. Yes, when they start going to grade 4, stage 4 CKD or stage 5, then definitely ACE inhibitors should be used with caution, because they can cause hyperkalemia. Until that time, we don't have to worry. So the other things that are there, obviously all these things should be corrected, and basic idea is to correct the underlying etiology, prevent acute kidney injury, slow the progression of CKD. These are all the important plans, that the goals that we have in the management of patients with chronic kidney disease.